start the session, but unfortunately he had to leave station for some urgent work, so that's why he has laid this responsibility on my shoulders. So I welcome you all on behalf of Melap, which is Medical Education Learning Point. That is the brainchild of Dr. Neeraj Jain, and he started in 2014. And it looks after, as per the requirement by the National Medical Council, that yes, now the quality concept has to be taken care on priority amongst the clinical diagnostic laboratories. And as we know, as ISO 15189 and the clause 5.6, that quality of examination is also one of the component that needs to be taken care of. So taking that in aim, so quality keeps on improving day by day with the recent advances. And for that, this session has been organized with the update in the microbiology. And this is the 9th such event that is being held under the umbrella of Melap. Now, first, I would like to invite Professor Rakesh Sehgal, who is Dean Academics and Head of the Department of Medical Parasitology at PGIMER. And he is also at present the chairperson of CSIC, that is Central Sophisticated Instrument Committee, and Group D departments at PGI Chandigarh. Group D means we have separate departments at PGI: microbiology, parasitology, and virology. So Sir is heading the Department of Parasitology, and he's the chairperson of all these 3 departments at present. Well, he has been actively participating in various administrative and organizational activities of the Institute. He has been a recipient number of national and international awards. Due to lack of the time, I'm not sharing the list of all those awards, and has published more than 250 research articles in various reputed journals, including chapters and books. And besides that, he has been active in the research and has recently published 2 patents, and another was in the process of being published. So he has at various national and international projects under him. Presently, 10 such projects are running. And his department has been a pioneer in developing and applying newer diagnostic techniques for the diagnosis of almost all the parasitic diseases prevalent in the country, and has been conducting quality research in this field. So today also he will be talking about another similar concept that is being the indigenous under his leadership in the department. Sir, now I would request you to please take on the stage. Thank you. Sir, you have to unmute your mic. Actually, Tripti has muted all the mics of the participants, so our also got muted.
Somebody muted me.
Yeah, sir. Yeah, Tripti actually muted all the participants' mics, sir. So he got muted. You have to.
Okay, yeah. Sorry about that. So now you can hear me?
Yes, sir. Very much audible.
So I am very grateful to the Melap, who has actually thought of allowing me to present some work as well as allowing me to talk on this forum. And as Dr. Gautam has said, that this is I think the 9th version of this update, and I would really love to participate in all the updates which are going to be there in the future. So I'll be talking about parasitic infection, LAMP, loop mediated amplification reaction, which is used for in parasitic infection, mainly for diagnosis. We are concerned mostly for diagnosis here with using molecular tests. Though there are other advantages, we can use it for, say, differentiation of parasites, genotyping. I'm not talking only of LAMP and other, I'm talking about other molecular tests. So one must remember that now the concept is that only antimicrobial resistance is important. However, that is not so. Parasites still remain important. They were important 10,000 years ago. They are still important. And I can assure you the number of parasitic infections since we got partition, say 1947, and now after 75 years, the number of parasitic infections even in India and other countries would almost remain the same. I am talking about the percentage of people infected by parasite. At that time, 1 in 4 or 1 in 5 people in the world were infected by parasite. The figure still remains the same if you put in an estimate. Populations have increased. Some countries have improved because they have improved hygiene and other things. The parasites have, some of them might have disappeared from there, but in developing and developing countries and other poor countries, the hygiene may be below par, and there these parasites proliferate and cause millions or rather billions of infections. One example is say roundworm, an estimate is say around 1 billion infections are there in the world by roundworm alone. So you can see the magnitude of the infection. The only thing why people don't bother too much is because this don't like roundworm doesn't kill a person immediately. So few it is causes a lot of morbidity rather than mortality. However, at the other end is one of the most common infections in the world, that is malaria. Still around I think 500,000 children are dying due to malaria each year. And the total number of infections still is enormous, though we are having a lot of control measures. However, it would be difficult to really eliminate malaria, for example, though one parasitic infection has been eliminated in the world, and that is guinea worm, not in the world, sorry, India, guinea worm infection. Now only few countries in Africa have it, and they had a very good control program. So progress has been made, but still parasites have a tendency to come back. Like malaria was near elimination from India, it came back with a vengeance, and still we have a lot of infections. Today, I'll be focusing on LAMP and how we can use it for mainly for diagnosis of parasitic infection. What are the advantages which we have in LAMP over, say, vis-a-vis the PCR test? So, what does LAMP stand for? LAMP is not like what you call a LAMP in uh, classical terms. It's a short form for loop mediated isothermal amplification. So LAMP. So this is what it stands for. And isothermal is the point we should remember, that is most important, because that is one thing which changed isothermal amplification versus thermal amplification, which is done in a thermal cycle. So the principle of LAMP was designed by the German scientist and patented by, this is Icon is a very famous company in Japan. This is a chemical company, and Shirato et al. In 2019 they patented this. And this was production of large amount of DNA amplification products having mutually complementary sequence and alternate and repeated structure. What they found that time was that it was a sensitive, easy, and a time efficient method. And they started, I think, initially with the diagnosis of malaria, because malaria was a problem throughout the world, and they wanted a rapid, specific, and sensitive test for diagnosis of malaria. You should remember that you have rapid diagnostic test for malaria, but there is a limitation of the sensitivity and specificity. Here, this LAMP overcomes most of that. What is the principle again is a novel one step close to loop mediated isothermal amplification assay. I repeat this because this is the important factor which will help you to understand. And it is via non-cyclic and cyclic amplification steps. First is a non-cyclic amplification. Cyclic means there is a loop formation. That is why this is called as a loop mediated. Here you are using more primers than what you are using in, say, PCR or even in nested PCR. 4 to 6 primers are at least required. And they are specifically designed for LAMP itself. You can't run the same with, say, a PCR primer. That would not work here. You have to design specific primers for LAMP, which would recognize distinct regions and the target gene. And usually the primers are not that big as compared to what you have in a PCR. They are much smaller, and this is why it works also much very well. Reaction process proceeds at a constant temperature. Now, the basic principle of thermal cycler is that there is cooling, heating, because that you have to have strand, break of the strand, then there is a annealing of the DNA strand. That is eliminated in this. So constant temperature is there. And this was possible due to a different DNA polymerase, which we are using here is the DST DNA polymerase, and this has a high strand displacement activity at 60 to 65 degrees centigrade, and that is why we need a constant temperature of say 60 to 65. You don't
So,
need to heat it to say 80, 85 and then cool it and so on. And
sorry,
these
sorry to
lead
interrupt you,
to,
Dr. Sehgal. Your slides are not moving. Sir, वो freeze
but
हो
here
गया है.
with me they are moving.
नहीं, हमारे screen पे I can see only first slide, lamp in
हाँ
parasitic
सर, I was
infection.
about to, मैं इसीलिए I was,
Why I don't know, because in my screen they are moving. Okay, let me see.
हाँ सर यहाँ पे अब आ रही हैं सर. Now
Okay,
it's moving.
so may I use it like this only? Fine. Now you see this slide.
हाँ जी, अभी लैंप
Now
वाली
I
slide
move
पर
to
आप.
the next slide. Can you see it?
Yes sir, principal has come.
Okay, okay, fine, fine.
Thank you sir.
And now you see the figure?
Yes sir.
Okay, fine. I'm sorry about that. So non-cyclic, as I told you, first steps are non-cyclic amplification. Then second in the middle, you see the cyclic, and then there is an elongation step. This is just a theory to explain in a diagrammatic form. And ultimately loops are formed, and that is why the loop of DNA loops are formed. And this loop is important because the number of loops that form, they form lead to a, if you are doing it in a tube, this leads to the turbidity in the tube, which you can even see in the naked eye. If it is not positive, it will not form turbidity, then it is a negative. This I will show you in the figure later on once I come to that. So this is the general principle to explain. Rest, the details you can actually read, but just to explain very roughly, I am using these diagrams. So now again it is moving. You are seeing the
Yes
next
sir.
slide?
Yes sir.
Yes.
Okay.
Coming.
So this is the primers which are being used, that forward primers again, and there are backward primers also. 4 to 6 primers are used. This again, if you see diagrammatically, you are going to see that forward F1, then forward internal primer, then backward internal primer, then there are loop primers, and so loop B, loop F. So these are the different primers you have in this, which is explained much better in this figure. So their internal primers, these are the small base pairs which you are using, forward internal primers and backward. These are called as FIP and BIP. And external primers, they are again forward primers F3 and B3. And optional loop primers, you may use that or not. They are not required, but if you do use them, sometimes in certain reactions they are used and may give better results also, because they give a better visualization of the test. So these are in rough. This is how the number of primers which are being used here. And this is again in the diagrammatic, again to explain what is the, and you see that outer primers, inner primers again, loop primers, and probe binding site is the gray area, and double stranded DNA template is the blue area. Just again, just to show you as an explanation. So this is how is the principle it will work. And though it is sort of a offshoot of say PCR, but it works much better than a PCR. The principle is different, because here again I emphasize that we don't require a thermal cycler. It will run at a temperature of 60 to 65 degrees centigrade. And again, this is to show you just example what we have doing also, like now come to parasites. This is the Giardia. I just give you an example of Giardia primers, and this is to amplify detect the EF1 alpha gene of Giardia, and for diagnosis also. So, and the target DNA is in the red, on the side there are the primer. So this ultimately, and that's part of this we have developed, and we have developed further some other primers to detect other genes of Giardia also, GDH and all, because they're the primers we have designed which are working better. I won't go into the details. These are just under process, and We are actually finalizing standardized, not finalizing. We have standardized the test using Giardia culture. Now we are doing it with the Giardia positive stool samples. So this is what is the application of LAMP? Well, actually, I am talking about LAMP in parasitic infection. But remember, it is not limited to parasitic infection. It can be used for anything. You want to detect, you want to highlight a target of some bacteria or viruses, you can use it. People are using it and they have developed that also. And the main important is it is the best thing to use in diagnostic laboratories, and results are there in 45 minutes to 2 hours. 2 hours, I'm telling you, higher limit. Usually within 1 hour to 1 hour, 15 minutes, you have a result in this. This is quite good that way. And so this uh, and can identify. And the other advantages is that very say femtogram of say DNA in a sample can be identified with this particular test. So this has a better sensitivity at times more than PCR, and specificity also is much better than PCR at times. Although there are studies going on and the comparison is still going on, but it works and has a sensitivity and specificity better than PCR, and it can be used for detection of viruses, bacteria, fungi, parasites, and even for that matter in other molecular tests. Supposing you want to identify a gene variation, and or I think presume it can also be used for that. So now coming to the detection, this is the main advantage of this. So that was the principle. Why we want to use a LAMP, and why not a PCR? I would, if I can standardize a LAMP versus a PCR, I would use a LAMP, because here if you see the visual detection, this is on the left is a negative test, and the right is the test which is positive. Here we are using a dye to see whether there is though you can just with the turbidity here on the right, if you see the turbidity in the positive, and here it is negative, no turbidity or very minor turbidity. So both are okay, equally good. But if you use a dye, the sensitivity of detection, visual detection improves to some extent compared to turbidity. So these are detection. If you don't have anything, you don't have a machine, you don't have a real-time machine, you don't have an electrophoresis, you can detect this result within say an hour or so using either a dye or just turbidity. Then there are machines which I'll show you later on. They give you a real-time visualization of what the amplification is. This is just in like a real-time PCR. You have this, and you can. This is a machine. This is the LAMP machine which is developed. It's very small. I would like to emphasize again here. This is a portable machine. It is a battery backup built in it, and this can run without light also, without power for 4 hours on that battery. We have used it without the power, and it works very well. For around 3.5 hours we could use it, and we have tried that. And because if you want for 3.5 hours also, you can do say in a run you can do 10 to 12 samples, and you can do a lot of samples in that also. Then other identification is by gel electrophoresis. This is the negative. This is just the copies, dimer sort of a thing. And these are the positive sample. And this is the ladder. So these are all cumbersome. Best is if you can identify with this, or you can use, this is actually give you, see if you can see the graph. And this is a graph like this comes in this machine and gives you a real time identification what is the positive sample and what is the negative. So this is no DNA is the blue one, and here the DNA of the positive sample. So coming again back to LAMP versus PCR. Why I am emphasizing on LAMP versus PCR. So on the left, if you see on my left, the temperature, reaction time, DNA extraction, product detection. So if you see the temperature here in LAMP is isothermal, and while here in PCR, you require thermal cycle. Reaction time of 1 hour or less, here 2 hours or more. DNA extraction, this is an important thing. You can directly put the sample, it will work with that. Or if you want a better result, you can extract the sample and use it. While in PCR, you need to require a DNA extraction. And or rather, Now lab can be modified to use for RNA detection also. So that's an important thing. Primers 4 to 6. Here 2 primers, 2 targets and so on. Equipment, dry block, heater, water bath. Now if you want to use it in a peripheral lab, a dry block heater or a water bath may cost you say in Indian rupees 25 to 30,000, and you can use it in a water bath. Rest chemicals you need and reagents you need. Rest you don't need a thermal cycler, and because a thermal cycler, even a, I mean, ordinary thermal cycler will cost you say around 4 lakh of rupees, and that is the cost also is important factor, and it cannot be used in the peripheral laboratory, while here with a block you can use that. Modifications, well, a lot of modifications have sensitivity 100 times better than a PCR and lower than a nested PCR. This sensitivity is up to the modification which we are using. Real time is better sensitive than uh, PCR and so on. But remember this, what we have done test, and with PCR we have found that we get better detection rates, and less amount of DNA can be detected with LAMP compared to PCR. Product detection here is with naked eye, thermodynamic analysis, fluorescent detection, electrophoresis, and real-time protocol. While here it is electrophoresis or a real-time machine you need to detect the positive sample. And real-time machine anyway costs much more than even a PCR machine. So, is the slide moving or not?
Yes, sir, moving.
Okay, okay. So now I'll come from this is just to tell you the some principles, and now coming to what uses it has in parasitic infection. Malaria, as I was already talking about malaria, it causes more than 1 million deaths. Now it is reducing to some extent, but still an estimate, you can go with this estimate that this is on the higher side estimate, say, but still I would say because of COVID also there has been a sudden spurt in malaria in African countries because control measures were at that time not good during that period. Now it's falciparum which causes mostly mortality, but now what we are seeing in India also is that Vivax is causing a lot of mortality. It is no longer the benign parasite we were seeing, it is causing same complications what falciparum was causing at one time. We are not really sure why it has occurred, but we are studying this in our department. We are seeing some mutation, but we are not able to pinpoint why, whether that is mutation is responsible for the change or it is a host response to the parasite, which is actually somewhere changed or we are studying that also, but at the moment it is ongoing. So we can with the LAMP we can do a prompt diagnosis, and that is what is required to treat this life-threatening illness. Because if we can say within an hour we can give you a very accurate diagnosis, the treatment would change. And in malaria, if you treat at the proper time, you can save more or less all the patients. If you delay it, then it becomes difficult. Then it affects all the organ systems and may become difficult to treat it. And the most important thing now we require, why we require a test like this is because microscopy is not good in the elimination stage, like in our Chandigarh and in Punjab. Consolidation stage is over. In Chandigarh, there are no indigenous cases of malaria. Punjab, they are now in the maintenance stage of malaria, and for that we require a very highly sensitive test, which can detect subclinical and low parasitemic infections, because that the microscopy will not detect. RDT will also not detect because RDT and microscopy have a sensitivity of say 50 to 100 parasite per microliter, while here it will detect even a nanogram to femtogram of this parasite DNA. So this is much better as far as malaria is concerned, and it can be used in the field. We are now planning, we have used in the lab, now we are planning to go to the field in Punjab and use the machine at the stage where this parasite is now prevalent.
Sir,
This is a recent study from India again. and they have done this, and they have shown this is just a review, and they are now actually saying this can be developed as a point of care test and as defined by WHO. And before that, if you see, if you want how to diagnose malaria, these are the tests which are being used for diagnosis of malaria. Clinical diagnosis, everybody knows. Microscopy is the gold standard which is used. However, now this is having a problem as far as uh, places where there is a few infections are there. Immunodiagnosis, antigen detection is the RDT, or rather it is the enzyme detection which is not being used, not the antigen detection. Then molecular diagnosis is PCR and lab. Flow cytometry is used, but we have used this flow cytometry, cumbersome, expensive, and can be used for diagnosis, but well, it is very expensive and mostly for research. But it is the lab where serology is now more or less outdated. RDT is the commonest one which is being used in the field. But I'll let me warn you about RDT. RDT, rapid diagnostic test, you get so many tests. But one thing I would caution is use the WHO has a list of RDT kits which they certify to be okay. From there, I will give you a sensitivity of that kit also, and you can use that. And this sensitivity, and do not use RDT which are not certified by WHO, because this will give you a false result. Either it will be false negative or false. We are facing this situation here. And when the same patient comes to us, we test it. It is sometimes positive in emergency. We found it negative. Even we go up to PCR and a lamp, and it is negative. And obviously, more that is the other thing is that they are negative. The more worse is when RDT declares it as negative, and we find it that it is certainly positive, and then the treatment is delayed. So for RDT also we need to have a certified test. So that is why we need to develop test which is much more sensitive and specific than RDT. So this is just to show you the different studies in the world which the people have done. And I'll just on the right side, I'll show you the sensitivity and specificity. And this touches say 100%. Some studies have shown 100% sensitivity and specificity. Well, I would say that you can take it as more than 95% sensitivity and specificity is there. Rather, the specificity is very good, touches around 100% from these studies you can see. And we have also done.
Sorry to interrupt, sir. Tripti was trying to say we have 2 more minutes to go, sir.
Pardon?
Sir, 2 more minutes to go.
Okay. Itna kam time diya. Okay, then I'll rush through.
So you have a lot of experience, sorry.
Yeah, so this is lamb for Chagas disease, and this has also been developed, but I'll not go into the details because this is not common in India. The Echinococcus also people have developed lamb. We are have not developed this because we are using PCR only for this. However, we have done then schistosomiasis. Again, this is not common in India. This is what we developed the visual test. First one in India we developed for malaria, and you can see that this is the sensitivity and specificity. Specificity somehow we were not very happy with it. Now it has been developed. We are finding the latest results are around 98% specificity. We improved on that. We changed some, tinkered with the primer, and we have got this. And now we are developing a lamp to detect drug-resistant mutants and parasites of if they are directly from the sample. So this is in process, and we have standardized this, and maybe next in the future I can show you the results also. So this is, we have developed a lamp for cysticercosis. We have used this lamp for detection of cysticercosis in DNA in the blood, as well as in the next slide I'll show you both the things. This is Gunjan Goyal, one of my students who had developed this. And this work we did with Northeast also, there in Assam, and some of the work was here. The predictive values was very good. And later on we developed it. We wanted to not use not blood but urine. Here the urine is that around the sensitivity overall is less, but specificity is very good. Sensitivity probably DNA we don't get in all samples, but still we can 60% urine samples we could detect cysticercosis, and we validated this with the PCR. And then fine. This next was we have also developed for acanthamoeba keratitis. Again, the sensitivity and specificity you can see is very good compared to PCR and so microscopy and culture. And then for in our department, we have also developed a lamp for Trichomonas vaginalis infection, and this is also working quite well. And this I can go you some other studies that people have developed lamp for Cryptosporidium giardia and surface water, which is important because here it is important. You need a test which is very sensitive because here the parasites are diluted. So you need a very sensitive test for this. So this is again for Cryptosporidium. Again, people have developed. We are also developing this, and it is also in the pipeline. And this was one of my, I mean, workers who I know very well, Dr. Mirda from AIMS, Delhi has also developed for EH. We have also developed and we have designed our own primers and these are being patented and we have got better results than what Dr. Mirda had got because we had made our own primers for this and this is in the process of these primers we are patenting now and maybe another 2-3 months we would be able to do that. So this is just to show you again Antimicrobial histolytica. Now just to sum up why lab. The test is equally as good as PCR. Well, or better. I would say that it is much more better because the specificity is much better, gives results within an hour. Sophisticated equipment like thermal cycle are not required and does not require complex sample preparation. I told you can directly use the sample. Can be done in any peripheral laboratory with basic equipment like dry water bath, very low cost. Results can be read with naked eye, turbidity, or using a dye can be used in the field and would be better than microscopy vis-a-vis the sensitivity and specificity. This is most important. And real-time lab can also be used to detect RNA. We can modify it. That is, sorry, reverse. This is RT lab is not real-time. Reverse transcript is sort of a system we can use. And this is what I wanted to tell you. Well, I can finish it here. So what I can assure you is that for any infection, lamb would if you but the only problem with any sensitive test is that you have to very careful. I again say very be careful about contamination. If you contaminate your I mean even say master makes or anything then you, because of the sensitivity that this will multiply and this will contaminate your whole system. So it has to be processed. The whole process should start in a different lab. The machine to run the test should be there in a different lab. Otherwise, you are going to end up in a problem. So that this is same with PCR. If contamination occurs, then you have had it. So this is all I would like to tell you about lamp in parasitic infections. I hope you have enjoyed the small talk, and if there are any questions or additions, they are most welcome.
Thank you so much, sir. So there is already one question I can see in the chat box. We can take only one question due to lack of time now. This is has lamp for malaria that PJ is using approved by WHO?
What lamp?
Yes, sir. For malaria,
Yes,
that
malaria has been approved, and because that was developed by ICON. Our test, which has we have developed, is not approved by WHO. We never got a WHO approval, but it is working now. What is there? At least 5 to 6 parasites. The lamp has been allowed by PGI, and we are using it routinely for patients, and they are working very well.
Thank you so much, sir. So thank you so much. I mean, it was really you have concise everything so nicely. The experience that you have over some, I think, 30 plus years at PGI and bringing this for the service of the society. I once again thank you all from this side on behalf
Thank
of.
you very much for the opportunity.
Thank you so much, sir. Now I hand over the mic to Dr. Anand Deshmukh, who will be further taking on the session.
Thank you, Vikas. Let's move to next speaker, Dr. Vikas Gautam. You may know him all. He's a professor in PGI Chandigarh, who has got experience for more than 22 years, excellent research record with more than 50 research publications. And as far as I know, he has got one patent as well on his name. And he's got ICMR Young Scientist Award as well. So he will be talking about sepsis diagnosis. Vikas.
Yes. Well, good afternoon, all. Am I audible?
Yes.
Yeah. Thank you. So I shall be talking about the sepsis and the diagnostic trio, that how a major challenge which is faced by a clinician in day-to-day practice, that yes, whether this patient is actually having sepsis. First of all, we need to understand that sepsis is a very loosely used term, which actually should be precisely used in a given patient. Because once you label that patient in sepsis, then yes, once correctly identified, then only we are supposed to give the systemic antimicrobial agents to the given patient. So how to diagnose this condition? I shall be, slide is not moving. Yeah, now the next slide is visible, I hope.
Yes, sir. Yes, sir.
Okay, thank you. So we need to understand, it is in the studies done way back in 97, 19, and if you look at this, that the once what happens, that clinician gives a statement that, see, my patient is admitted with me in ward or in a given ICU, and now he's running fever. So my patient was all right earlier, and now it is the infectious cause. But if we look at, less than 50% of those febrile episodes are actually attributed to infection, or 25%. Now, here, this is a study by Kumar et al., which shows the clinician side. Now, the clinician says, see, if I don't start the antibiotics on time, then there's average decrease in survival of this patient, which is around 7% by each passing. But though there is another study has come up which is not challenging this statement. Well, anyways, so fitting ourselves into the clinician's shoes. Now, which is the best practice in sepsis recovery for him or her, so that the patient life cannot be at stake because of our policy or the guidelines. Now, the patient has faith on the treating clinician that, yes, you please diagnose me with the available investigations. And as of today, if you look at the way microbiology is evolving, probably the most modern cultures performed by the microbiology lab are the blood cultures, automated blood cultures. It has clear-cut distinct advantages over the conventional methods which will come subsequently. And this is which has been further assisted by another revolutionary technology in microbiology, that is the MALDI-TOF. And clubbed along with that, completing the trio, is the automated susceptibility system. So coming one by one about this automated blood culture system, or we call it as CMBCS, that is continuously monitoring blood culture system. Now, how did this term evolve is that in conventional blood culture bottle, if you see, you keep the bottle and then on day one, say, and then after incubating, you do a subculture on day second, and then look up to it for the 5 days. Now, here it is what is happening. Now, luckily, many of us are now having these automated blood culture systems with us, that along with the culture which is being done, your panel where you are placing the bottles, that is also shaking the bottles, and that is why your recovery rate goes high. And then every 10 minutes it is taking a log reading. So that is why you call it as continuously monitoring blood culture system. Now, here we have to remember that first of all, we should be strong enough to have our sample collection in place, because the backbone of microbiology is how correctly the sample has been So to do that, we have these automated blood culture system. Now, as you can see in the image, we have this blue colored cap. Now flip it off, but remember you have to clean it with spirit, not with the betadine, which is common error being here. So just with the spirit, you have to clean it and then insert the vacuum cleaner, if you're collecting vacuum cleaner, then it has the bottle has to be inserted into this, or if by the syringe, then you insert the blood into this bottle with that syringe collected blood specimen. Now, once you have done this, of course, first the labeling of the bottle, the most important part, and then your TRF, test requisition form, has to be complete, clearly indicating which is the central line or the peripheral line. Now, I will go quickly through this, that first you the procedure is first you clean with spirit, then with povidone iodine or chlorhexidine. Please remember, if you are using povidone iodine at your places, please wait patiently for minimum 1.5 minutes. Now, while for chlorhexidine, that has got a drying period of 30 seconds. So if you are, and it has been shown superior to the povidone iodine, that chlorhexidine has the minimal drying period and of course more effective than the povidone iodine, because in this automated blood culture system, it is quite a sensitive system and very quickly your contaminants are being picked up. Now, another thing is, say, in this we have faced day-to-day challenges when the clinician says, okay, we have sometimes the renin is not there, something like that. So if we have a delay in sending these bottles to the blood culture lab, please don't refrigerate them. Don't incubate them at 37 degrees Celsius. You just keep it at room temperature, and ideally it should be transported within 2 hours. Now, there are different kind of bottles that you have in this CMBCS. Use the one which are resin containing if your patient is already on antimicrobial agents. And please note it down, once you have sent properly collected blood culture specimen along with 2 blood culture bottles you have sent, which are having adequate amount of blood, then please don't repeat it over the next 5 days. Okay, well, lab say the report has not come, so we need to send it again. No, there are only 3 conditions where you need to repeat it on the subsequent 2nd or 3rd day. So among this timing of collection or the amount, which one is more important? Just think of yourself. And here, if you look at out of timing and the volume, it is the volume that is more important than the timing. So depending on the company to company requirement, it is generally 8 to 10 ml of the blood that you have to inoculate into each bottle. Now, this is the graph which clearly states why so. If you use 10 ml of the blood, your recovery rate is only 40%. Means if you are sending 1 bottle to the lab. Now, if you send 2 bottles to the lab, then your recovery rate is almost double. That is up to 70-78%. Well, up to 3, if you go, it goes to 90%. But of course, practically, it is not feasible. So in general, that's what I may be a little harsh in saying, but that's what I state before my clinician friends, that if you want to send 1 bottle to the blood culture lab, please throw it into the dustbin rather than sending it to the lab. Always send 2 bottles and then ask the microbiology lab that why my culture was sterile despite my high suspicion. Now, another confusion that prevails is number of sets. Easy to remember. Please just number of set means by the independent venipuncture. Say, for example, if from 1 arm you are sending 1 bottle, then it is a 1 set of 1 bottle. If from the same arm you're taking the sample and sending 2 bottles, it becomes 1 set with 2 bottles. So this is how we define the number of sets. Now, 3 blood culture sets are needed that I told you only in 3 conditions, that is pyrexia of unknown origin. Say on day 1, you have sent 1 set with 2 bottles on day 1. It does not beep by the next day on day 2. Then send another set on the 2nd day. 1 set, 2nd set of 2 bottles. Again, there is no beep by the 3rd day. Then again send another 1 set of 2 bottles on the 3rd day, but then stop if there is no beep even on that 3rd set. So day 1, day 2, day 3, subsequently you are sending the 3 sets. Yes, in infectious endocarditis, as you know, on the 1st day itself, you have to send 3 blood culture sets in the first go within first 1.5 to 2 hours. Means if you are starting taking the sample at 9 o'clock, take 1 set of 2 bottles, 9:30 another set, 10 o'clock another set for suspected infective endocarditis. So this is how we are sending. And then the another advantage of this automated blood culture system over the conventional is labeling the CRBSI. Now here you can help your clinician colleague that yes, I can tell you whether your central line is the source of infection or not. Now here what you have to do, just clean it with the 70% alcohol. And please, now there is a change in the guideline. You need not discard any amount of blood. Earlier it was that yes, you have to discard the amount of blood if you're taking 2 centimeters, but now with this refined media, now you need not do that. Now, from the central line, please don't send the number 1 central line tip or central line alone. It should always be accompanied by the peripheral blood culture. And don't send central line tip as a routine that we receive, because clear-cut it's a guideline state that if you do this, then it only creates confusion and nothing else. Well, another important aspect that please understand that these blood culture bottles are not only for blood. These are for blood and all sterile body fluids. Well, for CSF, still the recommendation is not there, but still it is practiced worldwide. So this blood culture bottle, you can send all blood cultures, all sterile body fluids like your synovial fluid, knee aspirate, anything that pleural fluid you can send into this unless until it is a frank pass. Now here I give you an example when we use this blood culture bottle for inoculation in the CSF. That was a 7-year-old male child whose blood culture grew brucella. Then the senior resident calls up that we have a suspicion of meningitis also. So shall I send the CSF sample also in the blood culture bottle? Now, brucella only in 5% of the cases accumulate meninges. So he was suggested that you send one in the sterile tube as you send in a routine and the another one in the blood culture bottle, of course, in the pediatric bottle. The sterile body fluids, always get them in the pediatric bottle so that because that needs only 1 to 3 ml of the blood in general from one of the company. So when it was sent, your blood culture bottle was positive for brucella, but not the sterile fluid. So these advantages I've touched, that you have the dispatcher provisional report here in the conventional in 3 days. While here, when this is the general percentage that within 24 hours you get 75% of them positive. When we analyzed our data, we got some 68% were positive within this 24 hours, but within 48 hours, 98% of them were positive. Only 2% were left for the next 3 days to make it up to 5 days. Then yes, so once you have your organism being known to you, then accordingly you can have a de-escalation of antimicrobial therapy within 24 hours. Or if you have a gram negative in your bottle, stop for the cover for the gram positive and vice versa. And so you can have the narrowing of antimicrobial therapy within the first 24 hours. And of course, it has an economic benefit because unnecessary antibiotics are being not used. Yes, you have the advantage of a gram sling report, the ones it beats, but not so with the conventional. Now, that's what I stated, that if you have either of the gram positive negative, this is a multi-centric study, RCT from US as well as European centers, and clearly stated that if you have gram negative in the blood culture bottle, don't give a cover for the gram positive. Don't think, no, it might not have been detected. That is no justification. So then, besides that, then you have the advantages of the mysterious organisms isolation rate, which is high with this. Now, as observed, even for the suppressed pneumonia and its infancy, we have got a higher percentage positivity, which was more than the 5 to 10% we published also in IGMR. The another, those who are having the multitoph, they can have the advantage of, they must be experiencing that their some of the bottles they beep, but when you inoculate that on the blood in the McConkey agar, the organism does not grow. So here that MALDI helps us out. What we did directly from those blood culture bottles, which is given a beep, we did the MALDI identification. And then once these organisms were there, then we gave them the desired like microfluid conditions. And in 25% of such bottles, we could isolate the organism. Well, we have the experience that in the last 40 plus years, we could not isolate that organism, but could be made possible with the now. So here we could isolate brucella because of this automated blood culture system, we could not isolate it in with the conventional, though of course the Castana method is well defined. And then we published this work on the 14 patients. And this could be made feasible only with this automated blood culture system. And here, this was an interesting case, which is not even reported in the list of the organisms of this 5-year-old male child who have been running fever for 5 months, weight loss of 5 kg, school absenteeism, non-tetra hepatomegaly, 5 centimeter below the right costal margin, and splenomegaly. He was twice with IV third-gen cephalosporin and oral azithromycin, each lasting 7 to 10 days. The investigators not this, but then this was a simple case of brucella. This is how our clinician was struggling, but yes, automated blood culture system made it possible to treat it accordingly. This is another interesting case, which was some 8-year-old female child who was continuously febrile for 8 days. So starting by the Cyproamica, then our clinician escalated to Venco, Miro, and then finally antifungal was added. In what it turned out to be? It turned out to be Borrelia species, which you could identify on the staining only. And then, as we know that for the long-term relapsing fever, you with a single dose of doxycycline is good enough to make the child febrile. And when I went along with my senior resident, sister said she is not there and first time playing outside after turning a febrile. The another big textbook teaching was being changed by us when we combined our automated blood culture system with the multi-top. So here the coagulase negative staph, as we all know, is the common, we read that it is epidermidis, but it is actually not. This is what we have done in the healthy blood donors along the transplant medicine, and Hummels is the most common coagulase negative staph rather than epidermidis. And well, another important thing that we have to remember that this is not only for bacteria, but also for Candida isolation. So we need not send a special fungal blood culture once you are having the automated blood culture in space. And here also what we got, the isolation rate is high. And yes, the positivity rate also when during our NICU rounds, neonatology ICU rounds, when the question was posed that we start empirically the drug, but by the time your 5th day, you tell us sterile, our course is over. So first for bacteria, I've already told you the percentage goes 98% for 24 hours. We were surprised to see that even for candidemia, it goes up to 97% for first 48 hours. So now they have stopped their empirical antifungal if there is nothing coming out in the blood culture. Well, this is what we can help our clinician with by telling them whether your central line is the source needs to be taken care of or not, or we need to look for the other source. That this is a differential time of possibility. It is simple. Once you have sent the blood culture and the central line, if it beats 2 hours prior to the peripheral, then it indicates that it is the CRBS sign. Direct susceptibility, that is when you are sometimes trapped in a critical patient where you can't wait even for the next day. Now here, what we have tried and now, and we published also a couple of years back, I think it was in 11-12, and later on the sepsis biotype, a kit has also come. That what you can do directly from the blood culture bottle, say on day 1, you have got a beep in 68% of the cases. On day 1, then you're subculturing. On day 2, you're getting the growth and then the sensitivity. So you can save your time. And on day 1 only, when you have your beep with you, from that, you take the sample and directly put the sensitivity, and it corroborates quite well, especially for gram positive more than gram negatives. Now, then coming to the multi-top. Now, this is, as the name goes, it is matrix-assisted laser desorption ionization TOF, time of flight, mass spectrometry. And due to lack of time, not going into the principal details. Well, it totally changed our microbiology when 95% of the isolates which were isolated before it were limited to approximately 20 commonly isolated species. And even to us, 25% of the isolates were new. Now, here we worked on our isolates like being working on the non-fermenters. I worked on their whole genome sequence based isolates were available with us. And then we compared how precise is the multi-top. And then we observed that up to genus identification, it is 100%. In species also, if you make a dendrogram, only one isolate was being mislabeled as different species of bacteria, which was correctly placed with the help of multi-top. Now, even this outbreak Now you can use this when you are resource setting and it is not feasible to do the whole genome sequencing or the MLST of all this. You can make the dendrograms with the multi-TOF and it can help you out in deciding whether it was an outbreak or not. Coming to the last player of this trial, that is the automated susceptibility testing. Now, the lab should ideally provide you with the sensitivity zones or with the MSE values. Then accordingly, your dose can be optimized to the key PD targets. Now, this is the broad dilution method. As we all know, for colistin, now it is stated that none of the method is acceptable except for the microbial dilution. But in day-to-day testing, it becomes really difficult to do the microbial dilution, though, of course, we are made to do this. And even though for the automated testing here, the warning is only for colistin. Well, rest of this, you have this system to help you out, where I tell you the fine thing that for E. coli Klebsiella, you may get the susceptibility even done within 6 to 8 hours. Say on day 1, you have put the bottle by 9 o'clock. Even after 6 hours at times, you get the beep. Take out the bottle, say by 3, 4 o'clock. And then if you put a susceptibility by the night, in another, an average 6 hours by 10, 11 in the night, you can have the susceptibility also with you. So this makes a perfect trial with us. That is a continuous monitoring blood culture system, multi-TOF, and your automated susceptibility system. So MALDI is cost effective. See, now there are two scenarios. One is a standalone lab. You cannot put it on your own because 1 CR plus. But yes, all the labs can join hands together in a city like this is a trend in the Europe. And then all those labs send their identification isolates for identification to that central lab. It can be done. And here, if you look at the cost, it is just less than ₹5 per isolate testing that goes with the multi-TOF. So here we compare the automated blood culture with the PCR. This was the first D cases that I gave to my student, and we didn't found much of the edge. Well, the accreditation plays an important role when you're putting the system into place, especially the automated one. And yes, you keep pressing the pedal with your clinicians so that they are kept on guard and they send an adequate amount of blood in your blood culture bottles. And to a surprise, if you look at, we were thinking that pediatrician would be adding less amount of blood, but actually it was, they were adding more amount of blood in the bottles. So when we analyzed, we keep analyzing here that our surgical colleagues were need to improve while pediatrics were fully giving more blood. And of course, in pediatric population, it is 1 to 3 ml of the blood that we need, and the children have the higher load of bacteria in their blood as compared to an adult. So this is available under the only investigation, how to collect blood culture sample available on the PGI website. And yes, to win the clinician confidence simultaneously, we were coming up with the guidelines also. This is what I had been sharing you, that when this question was posed in microbial clinicians, within 40 hours, 98% of these isolates, that is including bacteria or candidemia, that can be detected by the system. And this is how we are aiding our clinicians in all this. Well, now this is about the diagnosis of the sepsis in the trial. The major question is now these is coming up about the wound infection. Do we need to give systemic antibiotics when the patient is having a wound infection? Well, this is just November, last month I presented in the Journal Club because a lot of research is going on to save our antibiotics in these localized infections, which are not actually sepsis. And the world is trying to come up with the antimicrobial agents that have microbicidal action also, and at the same time, promote the wound healing. Well, thank you all for your kind attention.
Thank you, Vikas. That was really enlightening. You're lucky you have all three systems together. We're still using manual sensitivities. We don't have automated sensitivity testing method. Anyway, any questions? I can take 1 or 2 questions. You can type as well on chat.
Well, I was trying to cover up so that I finish by 4.
Yeah, you touch everything. So let's move on to the next lecture.
Thank you.
By Dr. Ashish Sharma, who's head of department of renal transplant surgery at PGI Chandigarh. He has got more than 100 publications in national and international journals, and he has started kidney and pancreas transplantation, simultaneous kidney and pancreas transplantation at PGI Chandigarh in 2014, and the service is running really well. He's got very active involvement in promoting cadaver organ donation at PGI, and succeeded in more than 500 cases of kidney transplant. Dr. Ashish, he will be talking on tackling AMR with topical antimicrobial agent. Dr. Ashish.
But Ashish, you have to unmute yourself.
Please allow screen sharing as well. Hello, can you hear Vikas?
Yeah, your screen is being shared. But Ashish, you can, I think.
Okay, right. Okay, can you see my screen now?
Yes. Now you have to do the slideshow.
Yeah, at the outset, I would like to thank Melap and Vikas for involving me for this talk.
Yes.
So I'll be been briefed about the sepsis, the emerging of organisms currently which are not responding to the current generation of antimicrobial. So I'll just give a brief talk as to how we can help to avoid this situation. So there are no conflicts here except for small samples of the product which we are going to talk about today, and they were used for the study patients. So what is AMR? We all know that antimicrobial resistance, and as per WHO, it is one of the top 10 threats which face the humanity. So we're not talking about patients, and we're not talking about individuals here. We're talking about the humanity as such, and it's one of the top 10 threats faced by humanities. And we all know that the main reason why AMR is increasing is the exposure to antibiotics, right? Whenever you expose antibiotics to antimicrobials, the ones which are sensitive to it, they just die off, and a new breed of antimicrobials, microbes, they come up. So we need to prevent misuse of antimicrobials. And AMR has a significant impact on the overall cost to the economy. Not only it results in death and disability. I mean, imagine that just a couple of days back, I had one of my close relations who came to the hospital for an elective distal pancreatectomy. He's had an uneventful surgery. On day 3, he develops wound surgical site infection, which was an MDR bug, goes on to develop a pneumonia, and 7 days later, he just dies, right? And the relatives were puzzled, and we came for hospital for an elective surgery and ended up in death of patient for something which was very difficult to digest for the relations. And if it does not result in death, it definitely does result in a prolonged hospital stay, which will definitely increase the cost of everything. Right, and if you don't have these antimicrobials, I think surgery has got 3 main pillars: anesthesia, asepsis, and antimicrobials. If you don't have antimicrobials, your surgery is doomed. You will not be able to do any major surgery in future, right? So we need to tackle about this. But unfortunately, what we are having now is this is PGI data, and these are the different drugs which are there on the horizontal axis. The vertical axis shows the percentage of organisms, sensitive to that particular drug, right? So if you see, and these are different colors, so I'll just focus on the ICU ones, these ones. So if you see that all these and none of these even touches 50%, right? For the ICU patients, none of the antibiotics except for this minocycline and colistin, drugs like even meropenem, they are like down to 30%. That's a very scary situation where we are at the moment. Why would it affect me, right? Because introduced, I'm a transplant surgeon, so why should I be talking about antimicrobial resistance, right? So this is one of our patients who had a liver transplant last month, and this patient had Klebsiella organism in his blood, and if you see the sensitivity pattern, it's an MDR, multi-drug resistant organism, and unfortunately, this man has come to his this sepsis caused by this organism, and not only one, like we had a series of this mortality caused by an MDR organism. Now it brings to a very important question to us. I mean, at the moment, a lot of transplants, about 20% of our kidney transplants, all our liver transplants, and all our pancreas transplants come from diseased donors. And the kind of patients what we are seeing in the ICUs, they all have this kind of a bug. So there's another patient who's last month who had a donation, right? His blood had again grown Klebsiella, again the same sensitivity pattern. So it puts a question mark on us whether we should be proceeding with a therapy which is life-saving, like liver transplant or pancreas or kidney transplant, or we just abandon this. The family is willing to donate, but unfortunately, with these circumstances, we are not able to accept these organs. So that is why we are trying to create more and more awareness regarding this. So coming back to my the first slide, that the main driver is here misuse of antimicrobials. So can we prevent that? So this is data from the US. Unfortunately, India, there's no such data available, and it probably would not be available for the next decade or so. So if you see, there are different colors in this chart. The light pink shows, this shows that the number of antimicrobial prescription per 1,000 population per year, right? So if you see that there's a lot of variation here, right? And this variation cannot be explained by the variation in illnesses. It's only by the tendency of doctors to prescribe antimicrobials for various conditions, right? So obviously, there's a lot of variation starting from 529 to 1237, right? So we definitely need to look into these, study these, and what are the reasons and how can we avoid it. But the message is very clear that, okay, you can do much better than this. So I'll again give you an example, right? So this is one of, again, my patients. So she's a 95-year-old female. She's had a bad Parkinson, was bedridden for many years, right? So she's known to me, and she just asked for an opinion that she has this bed sore going on for the last 3 months. And she's been to various doctors, and she's been advised multiple courses of antibiotics, but nothing happened. The sore remains the same, and she's been ultimately now advised surgery. So they just came to me whether we should undergo this surgery at this stage, or we should just wait, right? So such wounds, chronic wounds, and leading to a lot of use of antibiotics, right? And that's another example, right? So that's a patient. This is one of my transplant patients actually who had diabetes, chronic diabetes leading to kidney failure. So all settings of diabetic foot, diabetes, immunosuppression. So again, like being treated with antibiotics, but with no response. So while we are worried about all these conditions, so I mean, Vikas introduced this medication to us, that there is herbal formulation that which takes care of both gram negatives and gram positives. So I became interested initially, but was very skeptical whether to use for patients. Our patients are very critical in the sense that they are on immunosuppression, and whether we should use it or not. So anyways, I mean, at the first, I was very, very skeptical, but then he showed the document that it's already been provided a patent and has been granted an award as for the by BIRAC for innovation as an innovation award, and has already been established and approved by various trials which are going at All India Institute of Medical Sciences, Delhi, and at one of the centers locally in our Tri-City. So this was a case which was very challenging. I was very reluctant to use it in the transplant patients, but this lady came to me and I said, okay, let us see whether this works or not. And we just started with this, and within 5 days, the relatives told me that this worked like magic, that whatever the sinus discharge, the sinus was discharging a lot of fluid, and just suddenly stopped coming, and the wound became red and pink, and the following week she had a little bit of more trauma, but then ultimately by day 40 it just healed. So I was really surprised, and so were the relatives, like, okay, that's worked something really good. So with that, I became more confident, and then we just thought that we probably will use this. This patient again was not showing any response to antibiotics to the extent that we had to just take distal part of the toe down. And so we started applying again this herbal formulation onto it, and it became more red and pink hair. And within a month or so, it had actually healed initially, right? So there's another patient who had a brachiocephalic fistula. So I know most of you would not be aware what is a fistula. So just to tell you that the fistula is a connection between an artery and vein here, and a lot of patients we have with chronic kidney disease. And once you are on chronic kidney disease, your kidneys are no longer working, and you use the dialysis machines to clear your blood of all the uremic toxins, and you need a good flow of blood. So what we do is that we join the artery and the vein, and then the blood flows through that system through the veins, and which can be taken out, put on dialysis machine, right? And this is again a patient who's got diabetes, and he came with such a bad wound infection at about 2 weeks. And most of these patients, in my experience, would end up, he was already on antibiotics. So most of these patients would end up in having a blowout of the artery, and would end up in ligation of their brachial artery. Not only the fistula, but even the brachial artery would has to be ligated. So again, we based on the earlier 2 experiences, we just started putting this medication without use of any oral antibiotics, because he already was on antibiotics, and to our surprise, that again this responded very well. The picture on the right is about 7 days after the initial application. This is another case of a brachiobasidic fistula. Again, this lady on day 2 only, she had a difficult surgery. She had multiple interventions, and following one of the thrombectomies done to take the clot out, she had a thrombosed fistula actually. So you see that on day 2, she's having some purulent discharge, and which required opening of the wound ultimately, and application of this sepal, and ultimately by day 10, we could actually start to resuture this wound again, and by day 21, this had healed completely. Again, and this earlier, this would have actually ended up in again ligation of the brachial artery rather than having this resolution. Of course, she was given systemic antibiotics, but our experience shows that despite giving given systemic antibiotics, not all, in fact, majority of patients would end up in a blowout of this anastomosis, leading to bleeding and other complications. So then we did the cytotoxicity study of this medicine, right? And we could see that there is no inhibition to the cells, which means that it would actually promote healing as compared to other local applications like betadine and sulfadiazine, which are known to inhibit wound healing. In fact, they are not recommended to be used on open wounds, although we always use a lot of, everybody uses betadine for local application, but it's not recommended. These drugs not only inhibit the bacterial growth, but also are injurious to the cellular healing pathways. So that's another case who had amputation. It's not my patient, but again, as a part of the study, we were recruiting patients. So he had a amputation because of traumatic injury, and which had led to Acinetobacter infection. And the wound was before the application of drug, and within. So this is the organism which was there, Acinetobacter, which was again a multi-drug resistant and would have required colistin therapy. But even then, we were not sure that whether this would we'll be able to close it primarily or not. And this is data from the WHO, and till date there's no compound that can inhibit or kill Acinetobacter, which is carbapenem resistant. But to our surprise, even our animal experiments, which were in collaboration with the group in Belgium, we could see that within 24 hours of application of this formulation, the Acinetobacter infection cleared up. And these are the culture plates which are showing the clearing of this bacteria. And within 3 days, we could actually resuture the wound, and the patient ended up having a good outcome. That's another patient who's had a mastectomy for carcinoma of breast. And again, for 4 months, this was a local discharging sinus, which was non-healing and which was growing MRSA. And again, application of this drug cleared the MRSA, and by day 10, the sinus discharge has totally disappeared. And this is the organism which you see that it's an MRSA, and no antibiotics were given. In fact, she's already received a lot of courses of antibiotics, and by day 30, the wound had actually healed, which is actually again quite surprising. And this is the same picture. So coming to the conclusion of my talk, I mean, so AMR, antimicrobial resistance, is a real threat which endangers the delivery of healthcare, right? The patient is coming to us for getting better, right? And we cannot endanger the life because of use of antibiotics. So we've demonstrated that effective local antimicrobials can help to reduce the use of antibiotics in chronic wounds, right? So this is one of the major reasons now for which chronic antibiotic therapy is given. Our population is aging. We are having we are the diabetic capital of the world, so we are having more and more diabetics. We are going to have more diabetic foods and other related infections, which are chronic, which go on for months altogether, and we don't need to give antibiotics for this if we have a good topical antimicrobial agent. And this formulation is promising, and it is effective against a lot of multi-drug organisms and has no negative impact on wound healing. So we've got something which can help. The trials are undergoing, and we're expecting the results very soon. So if such an agent is available, at least some part of the antimicrobial overuse can be taken care of. With that, I come to the end of my slide, and thank you very much. And I believe we have some time left for any questions.
Thank you so much, Dr. Ashish Sharma, sir, for excellent talk on AMR. Have you done any audit on how much you have saved on antibiotics after started using?
Yes, I mean, see, we just, I mean, we've done only in the initial period. So it was mainly meant to see the effectiveness. So we've not done any auditing in terms of finances, but definitely, I mean, these were all cases where actually they were not healing. So I think, I mean, the benefit is definitely going to be there. So, I mean, if somebody is going on these days, managing a chronic wound is becoming more and more expensive. You've got all fancy stuff in the market, which is very costly, right, as compared to Sepil. I mean, so I think, I mean, cost effective efficacy is definitely going to be there, apart from misuse of the antibiotics or the reduced use of antibiotics.
I agree. Any questions?
So I can see a question in the chat, the method of application. So it's just like you apply betadine. So just it's actually an oily formulation. So keep the wound moist also. So that also helps as compared to other agents like betadine is pure water soluble. So it just gets absorbed onto the gauze piece. It dries out. So it keeps the environment moist, which is again good for the wound healing. And frequency of application. So I mean that depends upon the kind of soiling. So we normally for dry wounds you can easily leave it for a day or even 2 days, and for the wet wounds we have to change as soon as the dressing becomes wet. So just remove it.
There's one more question. Where is Sepil available? Is it available in the market?
I think it is available in the market. I'm not sure. Maybe somebody else can answer this.
Yeah.
So we got, yeah, so I think already some answer is there. So we got a lot of samples. So we used samples so far.
So I think you can contact on those mobile number he has mentioned on chat if you want some samples and want to use in your patient. Any side effects?
I mean, in our limited experience, we've not seen any side effects. I mean, one benefit is definitely there that once you start applying it, you don't see any growth of organisms. It just wipes out everything. Otherwise, it's always, I mean, some culture will always keep on going, whether you apply betadine or whatever you apply. But with this application, your bacterial count comes down significantly.
Thank you. So I think we should move on to next case presentation that we have end of our seminar.
I mean, in fact, like I'll just add one.
Sorry.
No, the question. I'll add another comment. So we, I mean, we did this wound healing studies from our experience that the patient. I showed the brachiocephalic fistula where you join the artery and the vein. So in the vein, we know that the blood flow is always very less, but in the arteries, the blood flow is very fast. So when we join the artery and the vein, there's a continuous injury on the venous endothelium. So that in endothelium injury leads to hyperplasia of the endothelium. So in the patient who had this brachiobasilar fistula, when we were applying this medication, the endothelium of the vein became so hyperplastic that it almost closed the fistula. I mean, it occluded the lumen. So we had thought that, okay, the fistula, I mean, it happens all the time with fistula. So we thought that probably it is just a normal phenomena, and that is why how the fistula is getting. It happens in certain patients that the endothelium will get damaged and will proliferate, will occlude the fistula. So once the wound healed, we stopped. The fistula had already almost stopped. So there was hardly any flow. So once we stopped applying Sepil, the fistula again became functional after a few days. So I think that the proliferative effect of this was gone. And then we did the wound healing studies, which show that it actually promotes wound healing. So that's something very interesting.
Thank you. Shall we move on? So our next presentation is a case-based discussion by Dr. Vikas Gautam and Dr. Amit Sharma. Over to you, Vikas.
Yeah, Dr. Amit is going to present first, then I will come.
Oh, Dr. Amit Sharma is from Haryana, Rohtak, Haryana, and he's working as consultant orthopedics in Luton and Dunstable NHS Trust. He's been in UK for more than like 20 years now. So over to Dr. Amit.
Hello, can you hear me?
Yes.
Oh yeah, I was on mute. Sorry, the host wouldn't allow me to unmute myself. Hello, everybody. It's a pleasure to talk to all of you. Especially, it's a pleasure to be in company of Vikas, who's been my childhood colleague and friend. We studied together. So the topic today we were going to discuss. I work as an orthopedic surgeon. So my presence in a microbiology this seminar is mainly to discuss our infections and to seek any remedial solution or to seek advice from other experts on the panel if they have got any other ways to deal with difficult infections we come across. So I'm going to present a couple of cases and everybody's sort of welcome to join and comment on how to treat these infections, especially Vikas. If you could also do that. I'm going to start my screen share. It says I'm disabled to screen share. Can you enable my screen sharing, please? Thank you. Okay. So I'm going to start with a couple of cases that are actually I'm treating presently in my clinical scenarios. The photographs and the X-rays, they're not necessarily of the same patient because of patient data sensitivity. I've hidden everything, so they could be from some shared drives and are not case sensitive. So first patient I wanted to present and discuss was this 84-year-old gentleman who came to us. He was feverish, he had pain in his hand. So we looked up, got an x-ray, my SHO came to me. Can you see my screen? Are you able to see all the slides?
Yes.
Yeah. So he came up to me and said that, could you cast an eye on this chap? In orthopedics, everything, we don't look at people, we look at x-rays. So this was presented to me. He said the patient seems to be having pain in his arm. So can you see if we need to do anything? I said the X-ray looks fine. Send it to medics. So if he's got pain, just give him paracetamol. That's what orthopedicians do. But then I got a call from the A&E. I said that he doesn't look right. He has been he has had so many other problems. He's not maintaining his blood pressure and he's in a lot of pain. You need to better come down and have a look at it. So the history I got was that this 84-year-old man was drinking when he got stuck by a glass on his hand 3 days back, and now he had a large laceration and was having this kind of picture. So the important thing about this presentation was that he had pain on palpation, and there, as you could see, it was a bit pussy, and the patient was febrile, of course, and slightly delirious. When we looked at his bloods, his CRP was quite high. It was in the range of 250s. His WBC count was very high. And since his blood pressure was dipping and his pulse was high at 84 years old, we had to admit him. And we saw that his hand started blistering. And in a couple of hours, the infection spread. You can see the infection is spreading all along the forearms, gone up, almost up to the arm flexure. The bulla started developing. So a diagnosis of in such circumstances with the systemic features and the observation of necrotic skin, the patient having pain and rapidly spreading necrosis, a diagnosis of necrotizing fasciitis was made. So as we know that it's a life-threatening soft tissue infections which spreads along the soft tissue planes. So we took him to theaters immediately. So recommendation is the diagnosis is mainly made on skin discoloration, the bullous. In some very rare cases, you might feel crepitus. And there is a Lernick score, which I don't find very useful, but it is a tool in diagnosing these infections. We'll talk about that in this presentation also. And what we sometimes do is we do emergent frozen sections in our department, where we take a sample and send it for urgent micro and even pathology. So Lernick score that we use is basically based on CRP, WBC, hemoglobin, sodium, creatinine, and glucose. And based on that, if the score is more than 6, there's a 92% chance of having neck fash. And in this patient, he was diagnosed to have one. In ITU, he was on IV fluids, he was on antibiotics, he was on inotropes because he was done maintaining his BP. An arterial line and CVP line was on. This happened quite quickly because we could diagnose him early. Patient was rushed to theater and we did emergency radical debridement. Radical is the key word here. We had to remove every tissue that we thought is not viable. You could see we have still left a little bit, but that was viable. That was superficially, it looked discolored, but the skin was bleeding. But we still marked it and we kept a close eye on him. And like this is the present situation. Patient is under close monitoring and might need another reoperation. But fortunately, the moment the debridement was done, patient's parameters improved quite a lot. And he is now on the cusp of just coming out of the ITU. So for the discussion's sake, in a necrotizing fasciitis, what we found is operative findings which are important to look out for is liquefaction of the subcutaneous fat, dishwater pus, which is like, it's not very thick pus basically. You get very thin pus, which is like serum. Because the infection is spreading so fast, there's not even time for a proper pus to form. Muscle necrosis is found and venous thrombosis is found. And also, one of the most important critical thing about necrotizing fasciitis is time. You have to take action very, very quickly. Hemodynamic monitoring and systemic resuscitation is critical. You have to do that to save the patient. And hyperbaric oxygen, sometimes if you can identify anaerobic organism, and if your institute has it, we don't have it in our Luton hospital, and we don't have time to transfer these patients to a place where hyperbaric oxygen can be given. But if you're a lucky institute and you have it, they have proven to be quite useful in certain circumstances, but not all of them. Now, necrotizing fasciitis, I think you all guys would know, especially the ones in microbiology, that 4 types, depending on what kind of microbiological structures or microbiological pathogens are involved. They all have some distinct characteristics, especially what usually trumps people is type 3, in which if somebody has had marine exposure, been near a sea or somewhere, they've had a small cut and they come back with the exorbitant infections, which are not responding to anything. We should be very wary about these life-threatening infections. Antibiotics, we use empirical antibiotic to start with. Naturally, we don't know what thing is growing inside. We use with broad spectrum using the age-old formula. We start with broad spectrum initially. Penicillin, clindamycin, metronidazole, and an aminoglycoside all are put in. Definitive antibiotics then depends on what culture is grown later on. Penicillin G for Clostridium, imipenem, and doripenem, meropenem for polymicrobial. We add vancomycin and daptomycin if MRSA is suspected. That's the policy in our hospital. Now we know that this is life-threatening infection, and mortality rate is 32% if treated very well. And as I said, we can do everything. We can give antibiotics, we can give them hyperbaric oxygen, we can give them IV fluids, inotropes, but nothing will help. Patient needs to be rushed to the theaters to have the offending tissues taken out. And this patient will, after he is settled down, will need the plastic surgeon input for mostly skin grafting, but sometimes even flaps. So this was my first case. Any comments, Vikas or Dr. Anand, Ashish? Do you come across such infections? Is there any other way you deal with this in PGI?
So these are all necrotizing fasciitis. So, I mean, as you rightly said, I mean, the only therapy here is to do an early debridement. So, I mean, often if we have such a patient, sometimes a theater is not available. So just, I mean, sounds cruel to you. So but just make some nicks in the fascia. So, and gives you buy some time. So that's what we do.
Oh, I mean, just on the bedside, you make nicks.
Yeah.
Right.
And surprisingly, this is all necrotic tissues. So, I mean, the patient doesn't feel the pain. So,
right.
So we don't go to the normal skin, but the necrotic area, you can actually put incisions and just gives you some more time.
So how would it help with infection? Like it introduces oxygen inside, so maybe anaerobes would have, or it gives the facial tissues to a place to come out from.
So I believe that there is some increased pressure, subfacial pressure, so that
right.
probably relieves it. So it's
right, I get it. Yeah, because infection tends to spread along the path of least resistance. So the liquefaction instead of going along the facial planes. That's a very interesting thing, maybe. But fortunately, we stop. We're not as busy as PGI. We always have theater available. It's only a matter of deciding early for us. But that's a very valid point. Thank you.
We do often get critical patients with neck fash, and our policy is to start with meropenem and clindamycin, because we had a couple of E. coli, ESBL E. coli, which were not covered initially with we used to use ceftriaxone or piptaz-tazocin metro or ceftriaxone metro or tazocin. So, and a couple of patients we have used IVIG, those with staphylococcal, something like shock syndrome.
Mm-hmm.
So you're right, they have very high mortality, and surgical treatment with appropriate antibiotic is mainstay.
Vikas, do you foresee your wonder drug able to help in these circumstances? Do you think there is any role of topical antiseptic agents? Maybe not initially, but I think once we have done the debridement and patient is on the path of recovery, to prevent the further spread of infection.
Before that, I would just like to comment that in your list, you have included clindamycin, penicillin, and metronidazole, and aminoglycoside. So here, just one submission that we don't use metronidazole with the clindamycin, because clindamycin, besides the anti-inflammatory, it has also anti-anaerobic activity as well. And yes, coming to the second question, we have regarding this new product, yes, see, you are right. Initial management has to be as per the guidelines, because you have to be quick for the surgical intervention here, because it is known as a flesh-eating bacterium. If it is streptococcus, it will eat away within hours. So yes, later on, then we can apply the topical agent and then look at it. Once we have the cases, once we try it on, then we'll update you how well did it go. But I hope that, yes, that will help the patient in quick recovery. Thank you.
And this is the only infection that excites our microbiologist. Otherwise, I never see him on the ward. But when there's this kind of infection, he comes from his office where all your microbiologists hide. He comes from there and comes and has a look at the patient. So yeah, if you have time, Vikas, can I just go through another small case? Yeah. So we're talking about prosthetic joint infection. I mean, this is the bane of orthopedics for everyone. I mean, with the aging population, it is becoming even more kind of everyday event for us. The joints were done many years back. They're coming back. Patients are developing low immunity infection anywhere else. They're presenting to us with joint infections. Not just our fault of introducing the infection at the time of surgery. So I'll give you a case recently treated. A 97-year-old man. So around say 15 years back, had done his knee replacement. Simple, he was doing very well with it. When I'd done the knee replacement, I didn't expect him to live till 97 years, but he was here. So I got a call from the medical department saying that his knee is swollen, he's septic, and we cannot find any focus except for the knee. That focus of infection doesn't seem to be anywhere else. So yeah, we rushed over there. It was swollen, but it did not look any very red or anything. So we were very much of the opinion that you might have banged it, but since there was no other focus of infection, decided to aspirate. Aspiration in a joint with prosthesis inside, we don't do it on the bedside. So patient had to be taken to the ward or to the theater under all the septic condition. Is aspirated, and this came out. This was frank pus. So since the patient has not been septic or has not been complaining of swelling for quite a long time, we decided, and considering his age, we decided to do something we call as DARE procedure, in which we don't do anything dramatic, just open up his knee, removed everything that we can without taking out his cemented implants. We didn't want to, at 97, we didn't want to remove any of that stuff. So just took out the poly from between, took out all the synovium, and we put what now I've started to believe in for all my infections. We put cement beads, which are incorporated with vancomycin and rifampicin mixed. Left all of that in. You can see they're all inside. The idea is that they will keep eluding antibiotics for a long time, enough for the local infection to settle down. I think we all are aware of the biofilm that forms. The idea is that if we get to the infection before the biofilm forms, just doing a DARE procedure in which we debride and remove the poly and scrub the surfaces that are presented to us, we usually win in more than 50% of these cases. So this is just a depiction of how usually an infection presents. We should not ignore it. This is what we actually did. We try to do it within, if it is less than 3 weeks, and usually for acute hematogenous infections. We do thorough debridement with large volume irrigation, and 55% is the best success rate we have been able to get. Thank you. Over to you, Vikas. Any experience? You must be dealing with a lot of prosthetic joint infections. Have you started using the antibiotic beads? What antibiotics do you use in them? Mr. Gautam?
Yeah, sorry, Amit.
So what
What's the question?
I was saying that, do you have any experience with periprosthetic infections in which you go in for these cemented beads, and what antibiotics are you using for that?
No, not exactly. Because this area I've not discussed with my ortho colleagues.
Can I ask one question, Dr. Amit?
Sure.
How you decide on when to do dire and when to do two-step procedure?
Yeah, I'll take you back to this slide. So it's these are the few conditions I look for. Most important is time. I think the watershed moment is the formation of the biofilm, which the biofilm forms quite early, of course, but it's said that after 3 weeks it becomes impenetrable, even after doing an open reduction, even scrubbing or using any agent, you cannot break it. So if it is less than 3 weeks, so if the patient has had an infection which is less than 3 weeks, you know that he had a tooth abscess and the infection had traveled in the last couple of weeks, then I'd take the decision to do a dare, because we can scrub everything off, rub everything off, throw things we can throw, and it usually works, yes, but it's a hit and miss method. So time mainly.
So, I mean, it's interesting. I mean, if I would like to comment here, we've done biofilm studies with this formulation also, and it's been, this actually breaks the biofilm.
Yeah, that's what I've heard that. Gautam was telling me about that.
Yeah, so
it'd be interesting to see if this can be used inside the body, because I know it's a topical application thing. I don't know how the body will accept it inside.
So I had one of these synthetic graft patients in my slides. I think I mixed the two presentations while I was trying to prepare. So that was another interesting patient we had, where we put a synthetic graft for the dialysis access, the synthetic AV graft. So that's a PTFE material. So, and the patient had come, I think about 4 or 5 years later, he came with the infection of that site. And normally that would actually require removal of the entire graft and the removal of the access. So this patient did not have any other option for dialysis. All other veins were not suitable. So we tried this formulation, and I mean, it's the first time that I've seen that this the local site infection getting completely epithelialized and healed by application of Sepsil. Unfortunately, I mean, it did resolve once, but then the patient probably he didn't have enough samples. It was not available in the market, and he didn't come back to us. And then he had again a relapse. But I've never seen any wound healing happening over a prosthetic graft. This is the only instance where I saw it. Ultimately, the graft had to be taken out, because next time when he came, he was like in sepsis. So, but it's interesting if we have some more such patients, and you can use and see how, because the lab data does show that it breaks the biofilm.
Yeah, one thing I can think of, if we set up a proper ethical committee approved trial, we do, when I open up my joint, I use a proper brush like we do when we are cleaning our clothes, and we use a lot of agents like betadine, hydrogen peroxide. Now even I use acetic acid, believe that for some time, diluted one. So at that time, it's a topical use. So if there is no reaction and it is safe to use in a diluted form, maybe that is something we can look at, of course, especially starting with animal models and then trying to bring in to use in vivo, using it when we are trying to clean and wash the joints. What do you think, Vikas?
Yeah, we can give a try because we are already working on different formulations, like as you pose a question. So we have made its nano formulation as well, so that less amount can be used.
But how long does it need to be in contact with the bacteria to be effective?
I mean, if you
Especially
ask
to make the biofilm.
See, to biofilm, as Dr. Ashish has shown that case of a bed sore, which was long-standing for 3 months. There is another case from Chennai that was a long-standing bed sore for 5 months. So to say that there was a gap in that wound on the gluteal region between the skin and the wound. So when this was applied, previously the dressing was being done with the betadine and the daily dressing for over 5 months, and patient was admitted. On day 0, when this was started, by day 2 itself, the gap between the skin and the wound has filled up. By 6th day, another granulation tissue had appeared, and this patient ran away with the bottle and finally traced him and came back after a couple of months, and totally the wound was healed. So if you're asking me by what time the biofilm is broken, so in this clinical scenario, immediately within hours, it has done, because that's how over 5 months this wound, which was totally sleeping, got rejuvenated. And in vitro experiment, we have done the scanning electron microscopy. So within hours, we have shown in Pseudomonas that it can break the biofilm. And that paper is being submitted to be presented in the ESCMID conference. Just today is the last day for submission. So in the lab, we have shown, yeah.
Excellent. Any other questions anybody has, or any comments? Anybody from the audience? So I'll conclude my case presentations. Vikas, over to you. You said 1, I've done 2. So.
No, thank you. Thank you so much, Dr. Amit. Yeah, Dr. Anand is there.
Hi, thank you, Amit. Over to you, because we have a couple of minutes left. If you can.
Yeah, sure. Thank you so
much.
much.
Yeah. Thank you.
Hello. Please, sir. One second.
Well, good evening, everybody. My slides are visible.
Yes.
Okay. So this is how, as a clinical microbiologist, I'm just sharing the journey, how we started. So first, to win the confidence of the clinicians in India, we started with the circulation of our antimicrobial susceptibility data in 2009. Then by another 2 years, 2010, we started the regular circulation of the antimicrobial data. And finally, by the WHONET based, and then joined our clinicians here. And probably first time I started at our institute in the country that this trend was initiated. And what you have to keep up the pace, we came up with the guidelines. And then in the non-fermenters, working in that area, did the PhD also. And so, I mean, it was a learning for me, because our curriculum, now it is being on the stage of revision, so that the microbiologists, they don't come out as the lab microbiologists, but yes, they move from bench to bedside. Previously, that curriculum was not there. So whatever learning I have done is done from my clinician colleagues and from the patients who are the best teachers. So to share with you, this was a couple of years back when our former cardiologist in the department, the director also, he had a patient who was 35-year-old male, blood culture grew, gram-negative bacilli, sensitive to meropenem. But at the same time, he had the chest shadows also, and there also it grew the same GNB, which was sensitive to meropenem. Now we need to understand for our clinician friends that this is not enough, which is being classically explained in this given case. Because despite the sensitivity report, we are not able to identify this organism. Meropenem was being given in the optimal dosages. He was around 50-60 kg-year-old body weight. So 15 to 20 milligram per kg is the meropenem dose, and that we can go up to 20 to 40. But despite the susceptibility, this patient was not responding. Why not? Because this organism was Stenotrophomus maltophilia, which is intrinsically resistant to carbapenems because of the L1, L2 carbapenemases. But finally, when the intervention was being made, this patient was finally discharged. I'll come to it later when this was what we did in this. Now, another patient. These are the two recent patients last year only in our CTVS ICU. Now look at it. Now this patient, now we have constraint of time, so I'll go quickly through this, had been given all sort of antibiotics, ceftriaxone, pepsin-tazobactam, carbapenem, started with antifungal. You can understand the frustration of the clinician. The CTVS surgeon puts a lot of time and energy on operating upon this patient, and then losing the patient by simple infection is really becomes very tough for him. Then tigecycline, colistin, vancomycin, fenciclin, but still, now which drug are you going to have this? The one which let this patient walk out of the ICU. And this is just a very cheap drug that we finally empirically started. So I'll come to it. Well, I'll skip those slides. That antibiotics, this is a double-edged sword. On one end, yes, you are preventing the infection or treating them, but at the same time, you are leading on to the AMR. And please remember, this is a very important slide. What is happening? These are your susceptible bacteria in the gut of the patient, susceptible ones. Now, if you're using them non-judiciously, what you're doing, nature abhors a vacuum. You are wiping off these susceptible ones and filling them up with the resistant. So if you look at the ICU, like Dr. Anand shared in the beginning with the informal talk when we were having with along with Dr. Sehgal also, that there they have a very strict policy, no OTC drug as antibiotic is available in United Kingdom. But in our country, the scenario is different. So you are killing these friendly bacteria and creating the MDR parts. Now, if you look at this paper of Wisplinghoff in 2003, can you locate Acinetobacter in this? No, there is no Acinetobacter. But now, across the globe, barring few ICUs like in Netherlands or in Australia, you have the Acinetobacter, and that comes after almost 3 weeks. But now you are getting within the first few days this Acinetobacter. So in the globe, you have Acinetobacter, and Pseudomonas is the most common, and the third most common is now Stenotrophomonas, and the fourth is Burkholderia. And this is happening in India also. And the things don't stop here. Try to understand the most common pharmaceutical product recalls. As per the FDA report of 8 years, it is not Pseudomonas, but Burkholderia. So we need to understand that this is no, what organism are you talking about? We have not seen this thing, but now it's not the thing. It is creating a havoc in every field. And in our country also, we had our 76 children in a Mumbai hospital in a pediatric ward who were infected with this Burkholderia because of this unopened antibiotic vial. It only introduced this Burkholderia into those children. We'll come to it later. So this belongs to Pseudomonas. Your Acinetobacter belongs to a different family, but the Pseudomonas, Burkholderia, Steno, they belong to a same RNA group. Easy to identify. Nature has done a good job that out of 100 non-fermenters, these two after Pseudomonas can be easily identified by the simple biochemical reaction, and only these two are left if you have lysine decoxys positive. In the clinical scenario, now if you look at, you can just replace the heading of Pseudomonas and you have the similar picture with the, like this ecthymic agnosis, but it is not restricted to Pseudomonas. It is also caused by the Pseudomonas. This is just like a cigarette butt being placed on the skin, that kind of lesion. So that will give you suspicion this can be there. We had this patient where not only antemortem from blood culture, pus, respiratory specimen, even post-mortem specimen grew Stenotrophomonas. And that this is something way back in 2007-8 I'm talking about. Well, this was earlier near Pseudomonas cepacia, now Burkholderia cepacia. And it is a complex because now 22 recognized species are there. Its identification, that's why become important. Your MALDI will help you there because this Burkholderia cepacia, out of these 22 species, has the highest mortality, higher transmission rate. Like from extreme south, from Hyderabad, they were about to do the lung transplant. But if a child is infected with this, then you cannot do the lung transplant. So out of these 2 children, one could get the transplant, but another could not because that child was with Burkholderia cephalosapacia. So to help out not only those who have mulled it off like a 5-star hotel, but yes, those who have homemade kitchen, there also we published this scheme way in 2009, so that with the routine biochemicals, you can identify these bugs. Well, this Burkholderia has predilection for cystic fibrosis and CGD, known to cause septicemia and outbreaks. Cystic fibrosis, first identified in India by PGI, and similarly, second again Burkholderia from India, first time by PGI. Then septicemia, couple of isolates. So much so that ATCC requested us for the collection to be deposited at their place, but could not materialize because of the other things. Now, outbreak, I told you Mumbai hospital. First, I will touch you the treatment, then you will yourself find the answer for that CCU patient. Now, here we published this review where we gathered the whole data available till date in the literature about this Burkholderia cephalosapacia complex, about the clinical and the in vitro evidence. And similar experience was there that this piperacillin tazobactam, though reported by many centers for this organism, actually does not work. While this paper was there by Durham et al. Similarly, we had a patient where 3 times, despite the piperacillin tazobactam, Burkholderia was isolated. So you have the drugs for these organisms. The cotrimoxazole is the clear-cut drug of choice for Stenotrophomonas. Yes, also works for Burkholderia cephalosapacia, but there is no defined drug of choice for this organism because of this complexity of species. Then you have ceftazidime, minocycline, levoflox. Now, with these treatment, you will get the answer for that CTVS ICU patient also. Now, here, please remember, both these bugs are intrinsically resistant to aminoglycosides, not going to work. But yes, for Burkholderia, tobramycin is the only one that is for many countries is the last resort for cystic fibrosis children. Now, this, as I told you, Stenotrophomonas intrinsically is to carbapenem, while Burkholderia intrinsically is to colistin. Now, so looking at the description, we also tested doripenem against this, and we found that even meropenem resistant isolates were sensitive to doripenem. Now, this is, pay your attention. These are my favorite slides. This is a clear textbook kind of scenario and showing the injudicious use of antibiotics. Now, please note down, up to 2013, we were isolating around only 30 isolates of Stenotrophomonas. And then what happened? In 2013, you look at the carbapenems being used injudiciously or maximally used, and your susceptibility has gone down now to carbapenem. Which organism is resistant? Stenotrophomonas. So in 2014, your number was almost 4 or 5 times. Well, what happens now? After carbapenems are failing, you started using colistin. And then what happens? The very next year, you have from 30, you have 4 times your Burkholderia that is coming down. So things are not going to stop. Please remember, whatever you have in your armamentarium, you have to use it judiciously. Now look at, in that CTVS ICU patient, we gave a drug where we were suspecting that yes, now as per the Bispling of study, that these bugs are now likely to come because you have used carbapenem, colistin, antifungal, everything left with, and these bugs then come. So here what we found, the maximum susceptibility earlier of this Burkholderia cephalosapacia was to ceftazidime, purple. This was the highest. And then gradually we found that levofloxacin is now showing the more susceptibility. This was beyond, when we observed beyond 2016, because this is a published paper. But the latest, when this patient was discussed last year in 21, we had the levofloxacin, which has now gone high. Similarly, for Stenotrophomonas, this levofloxacin again had surpassed the others. And this is the another drug, which is minocycline, not tetra. Tetra was initially when we had not the minocycline disc. So it is the minocycline levo, which are the dominating. So what we did, I'll come to you while showing that graph, that which drug we use out of these two. And so that is why that becomes important. And now it is this Mumbai outbreak. Hats off to that Mumbai team that they could find out the source. They took some 300 samples to finally come down to one source, and that was unopened amikacin vial. And once you open this up, and then this rubber vial, inside that rubber vial, on the inside of this Burkholderia was surviving because it eats up aminoglycosides. And to surprise, these are the amikacin vial isolates, 2 isolates, and these are the patient isolates. Not a single nucleotide difference if you look at these cases, except one. So that was totally matching that this was the thing. And interestingly, for its simplicity, I know you are not this is the whole genome sequence based data. And here, as you look at, these were the isolates of this amikacin vial and in the patients, and they had a particular ICE element, integrative conjugative element, for which we are further working on, present only in these isolates. Then the story does not end here. Now, first time from India or probably from Southeast Asia, otherwise every new bacterial species comes from US and Europe, but we could pick up another new species with the help of our collaborator from the sister institute from IMTech here, this Stanotrophomonas. And what we were expecting, then we collected the data from other 4 centers, identified it with Maldi Toff, and we were expecting, okay, how many isolate percentage will have? Some 5-10 isolates will be there. But to our surprise, we had 40% of these isolates turned out to be this new species. Now, coming back to your CTVS ICU case, so what we did empirically, only levofloxacin. How much it costs? Hardly 100 rupees. And if you look at by the CIPLA, just 82 rupees for 10 tablets. And this patient was discharged. But if you look at the other patient who we had simultaneously, he was also colistin, vancomycin, Mino, but he had Burkholderia by this time. When we started Septron, it was late and we lost this patient. So much so, and then this was another request that we received from US, from one of the professor. He said, I need this article because I'm trying to treat a difficult patient with Cepacia bacteremia. And then he said, thank you very much. It was a very thorough review. So this is how we help each other now, not only in our country, but across the globe. So after going through all this, we could discover the new species. And then let's not talk about only the problem as a clinical microbial. We need to give a solution to our colleagues. So that's what Dr. Ashish has talked about, the topical antimicrobial agent. The patent was filed, granted in 2020. And the first prize it won in the innovation where even the IIT's engineers innovations were there. And finally now, as Dr. Ashish is telling about one patient, again, he get this thing because no more sample was available for this. So for the public benefit and for the benefit of the society, now it is available. So this product where we have saved a couple of diabetic foot amputations where the below knee amputation had been done in one of the surgery patient, luckily got engaged in the trial. And then the surgery people had planned for above knee amputation, but luckily he applied only this topical antimicrobial agent where it was growing anaerobe and his amputation was saved. His knee joint was saved. And then in bed sores and in other non-healing ulcers over the last 2+ years long studying ulcers, they have been treated with this topical antimicrobial agent who has antimicrobial activity and the rapid wound healing property. Well, thank you all for your kind attention.
Thank you, Vikas. 1 or 2 quick questions.
So Vikas, if you have a Stenotrophomonas and the sensitivity pattern shows both Septizime and Septran, so which one would you use?
See, I mean, as such, the drug of choice that is stated for Stenotrophomonas is cotrimoxazole, Septran, right? But here, now we are having the automated accessibility system with us. But here, your question can be properly answered if we have the MSC values for both the molecules, and then look at it, at how much lower full dilution is there with which.
But I don't think you report those values.
Oh, we are not actually here in this automated accessibility. Also, this is a challenge. They have certain breakpoints. They're not giving the exact. Of course, you can calculate. So, whether if it falls into those 4 or 5 ranges, then it can be doable. Otherwise, not. But yes. And for the given scenario, when you are having the report from our lab and you have both ceftazidime and cotrimoxazole, so we can use either. There is no, but if you look at in Stenotrophomonas, it's clearly said it's drug of choice. So you go ahead with the cotrimoxazole. But in Burkholderia, we earlier used to use ceftazidime as the empirical agent.
I mean, this knowledge is very important. Like a couple of weeks back, we had one patient who had a difficult vascular access for dialysis. So we did a very unique operation. We harvested the vein from the arm and put it in the thigh, and it grew this stenotrophomonas. But the report showed that it was intermediately sensitive to meropenem, which we had empirically started before. And my resident just continued it, saying that, okay, it still is intermediately sensitive. So this knowledge is important, that if you know it is intrinsically resistant, you probably should stop it. So I think we need to have more such interactive sessions.
Yes, actually what we do, that must have missed, because you can understand we get some 150 plus blood culture, the specimen you can understand. So we make sure it must have just passed that report. Otherwise our SRs are instructed that you look at the organism, even if reported susceptible by the VITEC, you have to convert it to resistant and then send to the clinician. So that lies the lecture on our part.
Yeah, and other thing is, don't test it in the first place. Just test only 4 antibiotics, what we do, because then there is no lab error on issuing any report saying that this is sensitive to any other antibiotic other than levoflox, tigecycline, Cotrim, and ceftazidime. Thank you.
Yeah, Dr. Anand, what we do, we have because it's an enable accredited department, so we have a critical call alert with us. So for blood culture and CSF and the body fluids, there, whatever organism is growing, so by 11-12 you finish our reporting, then our resident, because say as an example, on day 1 you have got a blood culture, on day 1 you have got a beep, and then you subculture it. On day 2 you have the growth with us. Now on day 2, when the growth is there, by MALDI we identify whether it is Burkholderia or Sertognas. So same time we tell the clinician that you stop your meropenem or cholesterol in this patient and start empirically with either levoflox or cotrimoxazole. So that is done for those specimens. But for pus or respiratory, it is not there. But it exists for those sterile body fluids and blood.
Sure. Thank you so much, Vikas, for highlighting and enlightening us about newer advances in treating patients with steno and difficult to treat patients with steno and Burkholderia. Thank you so much. And thank you again for inviting me to chair the session.
Yeah, thank you. It was a pleasure, Dr. Anand. For on a short notice, you have accepted our request.
That's fine. To conclude?
Yes, please.
It's over now. So when is the next meeting? Can we invite people from other states as well? That's another question.
Yeah, of course. That would be a pleasure, because Dr. Neeraj Jain frequently keep doing this update.
Okay.
So another next 2 months, 3 months or so, again, we will have the Microbiology Update-10.
Okay. Thank you.
Yeah.
Thank you all. Bye.
Thank you all. Thank you so much. Thank you on the behalf of Melap, Dr. Anand, Dr. Ashish, Dr. Amit, Dr. Sehgal, sir, for being with us and sharing their views.